Good day everyone. So the first topic that we have is uterine rupture to be discussed by Miss Bihag Cheer Angel, Miss Bonghanoy Rachel Dayan, and Miss Caballes Natalie Ann. Definition: uterine rupture is a rare but serious childbirth complication that can occur during vaginal birth. It is described as spontaneous tearing of the uterus that may result in the fetus being expelled in the peritoneal cavity. This can cause severe bleeding in the mother and can suffocate the baby. Etiology: uterine rupture occurs most often along healed scar lines in women who have had prior cesarean deliveries. Other predisposing factors include congenital uterine abnormalities, trauma, and other uterine surgical procedures such as myomectomies or open maternal fetal surgery. Causes of uterine rupture may include uterine overdistension. This is due to multifetal pregnancy, polyhydramnios, or fetal anomalies. Next is external or internal fetal version, latrogenic perforation, excessive use of uterotonics, and lastly, failure to recognize labor dystocia with excessive uterine contractions against the lower uterine restriction ring.
There are two main types of uterine rupture: the incomplete and complete uterine rupture. In an incomplete uterine rupture, the mother's peritoneum remains intact. The peritoneum is the membrane that lines the abdominal cavity to support abdominal organs. It also acts as a channel for blood vessels and nerves. An incomplete uterine rupture is significantly less dangerous with fewer complications to the delivery process. During a complete uterine rupture, as seen in the picture, the peritoneum tears and the contents of the mother's uterus can spill into her peritoneal cavity. The peritoneal cavity is the fluid-filled gap that separates the abdomen walls and its organs. It is suggested that delivery via cesarean section or C-section should occur within approximately 10 to 35 minutes after a complete uterine rupture occurs. The fetal morbidity rate increases dramatically after this period.
Now let's talk about the signs and symptoms of uterine rupture. Uterine ruptures are associated with a number of symptoms. Some possible symptoms may include excessive vaginal bleeding, sudden pain between contractions, abnormal abdominal pain or soreness, recession of the baby's head into the birth canal, bulging under the pubic bone, and sudden pain at the site of previous uterine scar. To continue, loss of uterine muscle tone, rapid heart rate, low blood pressure and shock in the mother, abnormal heart rate in the baby, and lastly, failure of labor to progress naturally. And these are the signs and symptoms of uterine rupture.
Now we are going to discuss about the management of uterine rupture. For the nursing management, the nurse has to monitor for the possibility of uterine rupture, assist with rapid intervention, prevent and manage complications, and provide physical and emotional support to the patient. Under the medical management of uterine rupture are the following. Initial management consists of resuscitative measures, that is, management of shock, counseling and support to the patient and her attendants, inform them about the situation, the surgery, and maternal and fetal probable outcomes. For the pharmacologic management, it focuses more on the prevention of uterine rupture. Beta-adrenergic agents and procardia are the medications to reduce sensitivity of uterine myometrium to oxytocic and prostaglandin stimulation. These medications also increase blood flow to the uterus. Under the surgical management, surgery is the mainstay of managing uterine rupture. Available surgeries are uterine repair on one hand and uterine repair with bilateral tubal ligation, and hysterectomy or the removal of the uterus. Treatment of uterine rupture is immediate laparotomy with cesarean delivery and, if necessary, hysterectomy.
And here are some relevant pictures for you to see.
Good day everyone, I am Miss Rachel Diane V. Bonghanoy and I will be discussing our nursing care plan for uterine rupture. First, for our nursing assessment, we have our physiological problem, which is acute pain. Our subjective cues states that our client verbalized that she experiences sudden pain in between her contractions and that it is very painful. Our objective cues shows that her vital signs, for temperature it's 36.9 degrees Celsius. Her pulse rate is 118 beats per minute. Her respiratory rate is 26 breaths per minute. Her blood pressure is 80/65 mmHg, and her fetal heart rate is 101 bpm or beats per minute. As you can see, her pulse rate and respiratory rate is higher than normal. Her blood pressure, however, is lower than normal, and the fetal heart rate is higher or abnormal. For our nursing diagnosis, we have acute pain in the uterus as evidenced by low blood pressure and rapid heart rate related to rupture of the uterus. Our scientific basis for this is that a uterine rupture can be preceded or accompanied by several types of changes in uterine contractility, including hyperstimulation, reduced number of contractions, and increased or reduced baseline of the uterine tonus. It can cause abdominal pain, vaginal bleeding, low blood pressure, shock, abnormal heart rate in the fetus, and a change in the contraction pattern or a non-reassuring fetal heart rate tracing. Patients may describe acute onset abdominal pain that begins with a ripping sensation. Subsequent contracts are often quite painful. Our objectives of care is that we come up for our general objective. After 3 days of nurse-to-client interaction, the client will be able to demonstrate the use of relaxation skills to control pain or discomfort. For our specific objective, after 24 hours of nurse-to-client interaction, the client will verbalize reduction or relief of pain, display improved well-being such as baseline levels for pulse, blood pressure, and respirations. Our nursing actions we have come up. Number 1, continuous monitoring of maternal and fetal status and progress. Its rationale is to identify early signs of dysfunctional labor, fetal distress, facilitate prompt, effective treatment of emerging complications. Our second nursing action is to reinforce relaxation techniques. This is to minimize physical or psychological stress. Our third nursing action is to encourage verbalization of anxiety, fear, or concerns. This is to provide emotional support. Our fourth nursing action is to explain all procedures. This is to lessen anxiety of the mother and for her to understand the procedure so that she may cooperate properly all throughout. Our fifth nursing action is to provide a quiet environment conducive to rest. This is to allow the patient to rest properly and comfortably. Our sixth nursing action is to position change lateral Sims, the lateral Sims position. This is to minimize the effect of complicated labor on the mother and the fetus. Lastly, for our collaborative nursing action, which is the seventh, is oxygen per mask as indicated. This is to minimize effects of complicated labor and to provide adequate fetal oxygenation.